Hi, I'm Dr. Amber Hart. I'm a GP IBCLC working at O&G Consulting Group, and today I'm going to have a chat to you about some of the common breastfeeding issues that may arise in your day-to-day general practice. The first thing that I'd like to emphasise is that the vast majority of breastfeeding issues are actually related to a suboptimal latch and instability of the baby at the breast. So regardless of what the acute issue is that they present to you with, be it mastitis, thrush, vasospasm, if you don't address those underlying latch issues, these women are going to continue to represent, and worst case scenario, they're likely to stop breastfeeding a lot sooner than they normally would have. So with that being said, we'll get started with infective mastitis. Now, the Royal Women's Hospital has a really fantastic clinical practice guideline on managing mastitis and breast abscesses. So I would highly recommend that you bookmark that on your work desktops. The most common time for women to develop mastitis is in those first 6 weeks postpartum, but it can occur at any stage when a woman is breastfeeding. Staph aureus is by far the most common organism, but occasionally we will see a strep A or B mastitis, an E. coli mastitis, or occasionally an MRSA mastitis as well. Mastitis can very quickly progress to sepsis and breast abscesses, so it's really important to get on top of this quickly. So if you have a woman who's breastfeeding present to you with a red, hot, swollen, tender lump or wedge in their breast, get started on treatment as soon as possible. Now, because of the staph being the most common organism, flucloxacillin is our first line medication of choice, 500 milligrams 4 times a day. The guideline says 5 to 10 days. I often find that women do need the full 10-day course, so make sure that they have a repeat on their prescription. If there are any issues with the Fluclox, you can prescribe Keflex or clindamycin, and you can have a look at that Royal Women's Hospital guideline for the doses with that. But it's really important to note that the treatment of mastitis doesn't stop with antibiotics. If you don't address the cause of the mastitis, it's either not going to clear or it's going to recur very quickly. And it's incredibly important that you let the women know that now is not the time to wean. It's really important that that infected breast is drained often and well. I also prescribe regular ibuprofen and or paracetamol for these women to address the inflammation in the breast, and it's really important that they have plenty of fluids and get lots and lots of rest. Cold packs to the affected breast can provide comfort, but it's also going to address that underlying inflammation. Now, I do often tell women to slightly increase the frequency of feeds when they have mastitis to make sure that that breast is really well drained, and where possible, get the baby to start on the infected breast for a day or two, just to really make sure that blockage is cleared. If the baby can't go to the breast, so if mum is in too much discomfort or the baby is fussing at the breast, then it is important that she either hand express or pump to ensure that that breast is drained. Please make sure that you do warn women that it's very common to have a transient reduction in supply in that breast. It usually does bounce back pretty quickly after the infection clears, and what usually happens is the other breast will compensate by increasing supply. Sometimes the milk can taste a little bit salty, and some babies are particularly sensitive to this. So if they do start to fuss at that infected breast, it's not because there's any problem with them drinking from that breast, it's just that either the supply is a little low or the breast milk tastes a little bit different. So we'll move on to nipple thrush now. Nipple thrush is really quite overdiagnosed with relation to breastfeeding issues. And the reason for that is because the symptoms of thrush are very, very similar to the symptoms of nipple trauma, vasospasm and dermatitis. It's important to recognise that nipple thrush is not just a candida infection of the nipples, but also an infection of the duct. And that's why we do that 3-stage treatment. If you are intending on treating mum, then you need to assume that the baby is colonised as well, regardless of whether they have signs of thrush in their mouth or not. So if you have a mum that presents to you breastfeeding who has painfully sensitive nipples, they have sharp shooting pains, aching pains or burning pains in the nipples and or the breasts, and those pink sort of shiny nipples, and you think this is thrush, then the treatment must be threefold. Now, if any of you are familiar with the Royal Women's Hospital guidelines, you'll know that they start off with oral fluconazole and then they switch to nystatin. The reason for this is that when those guidelines were first developed, fluconazole was very expensive and prohibitive for a lot of women. The guidelines are in the process of being rewritten, and we now no longer recommend switching over to nystatin unless there is a particular problem with the woman taking the fluconazole, or you're considering starting her on domperidone for low supply. So if the woman has nipple pain, we start on fluconazole, 100 milligrams a day for a week. If she has breast pain as well, then we'll continue that for 10 days and then wean gradually over about 3 weeks. So after that 10-day course of a daily dose of fluconazole, go to 3 tablets a week for a week, and then 2 tablets a week for a week, and then 1 tablet a week for a week, and then stop. At the same time, she needs to be popping Ductarin gel on her nipples 3 times a day and applying Ductarin gel to the baby's mouth 4 times a day for the first week, and then daily for another week. Now, you do need to know that Ductarin product information says that it's not suitable for infants under 6 months. This is actually related to the way the medication is administered. So it's not safe to administer the medication on the spoon directly into the baby's mouth because it's a choking hazard. What you need to advise parents to do is measure out that medication onto a spoon and then apply it to the cheeks, the tongue and the gums with a clean finger. The other thing I'll briefly mention about thrush is that the medication not only has antifungal properties, it also has anti-inflammatory properties. So often women who have these symptoms but don't actually have thrush will improve a little bit on this medication. So if you have a mum who comes in, you think it might be thrush, you put them on the treatment and they improve a little bit but not completely, or they improve and then as soon as you stop the treatment it rebounds again, it's likely that they were actually benefiting from the anti-inflammatory properties and not the antifungal properties, and it's probably some other underlying cause. So a good idea to refer them off to a breastfeeding specialist for a full breastfeeding assessment. Now moving on to domperidone for low supply. Domperidone works by increasing prolactin levels in the breastfeeding mother. And prolactin is the hormone that's responsible for breast milk production. Now breast milk production is under autocrine control at this stage. So if those breasts aren't being drained well and often, the domperidone isn't going to work, okay? So mums really need to be either feeding or pumping at least 8 times a day and ideally up to 12 times a day. Generally, we'll start with a dose of 10 milligrams 3 times a day, and this can be increased up to 20 milligrams 3 times a day. And in fact, in America, they actually go quite a bit higher than that. Most women will stay on the medication for about 4 weeks. The peak action is said to be around about the 2-week mark, but women will often notice an increase in their supply well before that 2-week point. When it comes time to stop the domperidone, it needs to be weaned slowly. So I generally recommend dropping 1 tablet a day over a week and gradually reducing like that. If at any stage mum notices a reduction in her supply during the weaning process, then I recommend going back up to the most recent dose and staying at that for 1 to 2 weeks and then trying again. And often that second wean is more successful. That being said, we do have some mums that need to stay on the domperidone for the duration of their breastfeeding, and we don't have any evidence of harm from doing that. Now, it's very important to recognise that domperidone is being prescribed off-label here, so informed consent is really, really important. There's been studies that have shown adverse cardiac events related to prolonged QT syndrome. This was in elderly patients who were receiving IV domperidone at much higher doses. There's no evidence of, or there's been no reported cases of adverse cardiac events in breastfeeding women, but very important to take a thorough history and document any personal or family history of cardiac arrhythmias, palpitations, unexplained dizziness, or any family history of sudden unexplained death. The medication can also interact with macrolide antibiotics, SSRIs, Mayo inhibitors, and fluconazole, so make sure you document a thorough medication history as well. The medication itself is usually quite well tolerated by women. The most commonly reported side effects are things like tummy upsets, dry mouth, dizziness, headaches, and generally these side effects will improve with time. I don't generally do an ECG pre and post treatment unless there's any concern about a history of palpitations or any sort of cardiac symptoms. So the bottom line with domperidone is This is only going to work if mum is draining those breasts often and well, and it's often a good idea if you're going to start these women on domperidone to have them seen by a breastfeeding specialist so that they can work on those underlying issues. Really what all this comes down to is a lot of these breastfeeding issues can be prevented with good education and support. I would recommend that you suggest that your antenatal patients attend antenatal breastfeeding preparation courses. I do run one once a month through O&G Consulting Group, and more information can be found on my website. And if you have any questions about any of the topics that I've presented here or any other breastfeeding or sleep and settling issues, please feel free to contact me. So thank you all for taking the time to listen to my presentation about common breastfeeding issues in general practice. I hope it provides you with some tools to support your breastfeeding patients, and please don't hesitate to contact me if you have any questions or concerns in the future.